All right, everybody, welcome to Optometric Education Consultants National Webinar Series Tuesday Night Edition. Tonight, we're going to be talking oral pharmaceuticals and eye care, the common, the uncommon, and beyond with Dr. Greg Caldwell, a graduate of the Pennsylvania College of Optometry, where he also did a residency in primary care and ocular disease at the Eye Institute. He is currently in private practice as an ocular disease consultant, with his primary focus on the diagnosis and management of anterior and posterior segment ocular disease. He has been a participant in multiple FDA clinical trials. He has truly integrated nutrition, prevention, and wellness into his patient care and truly practices integrative optometry. He is a co-founder of Optometric Education Consultants and co-administrator of OCT Connect on Facebook. He has lectured extensively throughout the U.S. And many European nations. In 2010, he served as president of the Pennsylvania Optometric Association and was on the AOA Board of Trustees from 2013 to 2016. And in 2023, he was named one of the top doctors in the U.S. by Newsweek magazine. So with that, Greg, please take it away. I'm looking forward to hearing this.
Thanks, Joe, and everyone out there. This is a new presentation, so bear with me if it gets a little choppy from here. I have to thank my extern, Maddie, who helped me today, as when I opened this up after building it literally yesterday, this morning, every picture was corrupted. So in between patients, and she was seeing patients, I was able to put all the photos back in. So Maddie, I think you said you were going to join tonight. Thanks for helping me out today. So we're going to do oral pharmaceuticals in the eye, the common, the uncommon, and beyond. Um, Not too much here that I have to disclose. I'll disclose it for the purposes that we have to do it as it, but I don't think I'll be covering too much in here. So Alcon to Dompe to the Optometric Advisory Team, non-salaried affiliation with Pharmanex, registry. Here's the key, is that it was all prepared by me. No one's telling me what to say. The content, if I do mention products, which I will, I'm not going to claim any bias or superiority. As you think you all figured out, Joe and I are half owners of Optometric Education Consultants, and everything has been mitigated. All relevant relationships have been mitigated. I usually don't do this, but I wanted to walk everyone through is that we're going to do antivirals. We'll probably spend the majority of the time there because when I do these talks, it's where a lot of people want to spend time. We'll talk analgesics, steroids, oral allergy meds, Diamox, and that sulfa allergy that's out there. And hopefully, if you have time, we'll get into some antibiotics as in the orals. So the first polling question right off the bat is two of them actually, is how many herpes viruses infect the eye? And then what is your go-to oral antiviral for hepatic disease? So, how many herpes viruses infect the eye? And what is your go-to oral antiviral for hepatic disease? And really, this polling question or this came up whenever I was doing a talk, and someone asked in the audience, like, "Hey, like my dog gets herpes or my cat has herpes, and am I able to contract it from my cat or dog?" And I was like, "Good question." I said, viruses. I didn't really realize, cats or dogs can get them. So let's just, what's your thoughts? How many herpes viruses infect the eye, and what's your go-to? 2, 3, 5, 8, 10. I don't know. That's why I'm here. Or acyclovir, Famvir, Valtrex, valacyclovir, or you don't have one. And maybe after tonight, you'll have one. All right. So just for the fun of it, it looks like we have a pretty good amount of people that have weighed in. Don't
And just
forget those
so
poll.
everybody
Yeah, Joe.
knows that when you're answering the polls, you have to go to the icon on the right. In there, you click on that and you'll find the polls if you can't find them.
Yep. All right. Looks like we got the trend here going. So let's display it. And we have the majority of 2. We have 3, 5 as 10%, 8 and 10. And you don't know. And that's why you're here. Again, that's why we give it. So it looks like 2 was the winner. And the answers I'm going to display it here in a second. And then I'll close that question. And then display, looks like 56% of the time people go with Valtrex. It's kind of my go-to. I'll explain why as we go through here and hopefully maybe lean some people that way. Again, not claiming superiority, but there are a few reasons why that medication is just a little bit helpful when it comes to treating. So, some fun facts about herpes. It's the leading cause of human viral disease behind influenza and cold viruses. There might be more, but at the time of building the lecture, there was up to 130 herpes viruses that have been identified, and they can affect, animals. There are 8 of those 130 that infect humans. Sometimes they break down the herpes human virus 6 to 6A, 6B. So you could say 9 if you want to split them. If you keep it as 1, then it's 8. But 5, the answer was 5 to that question would be how many affect the eye? And that's herpes 1 and 2, the zoster virus, that makes 3, Epstein-Barr, and the cytomegalovirus. And I think everyone out there knows that if you're in patient care or, older than 4 years old or, older than 20, that you probably have this virus in your body. If you would test your blood, you would probably test seropositive. As people by age 60, 100% test positive. Now we see patients, so I'm sure one of those times when we were sick as a student or sick in patient care or sick when we first started or going to conventions, we probably picked this virus up, um, and it just lives within us. So again, herpes human virus 1, 2, 3, 4, 5, 6, 7, 8. And then those that affect the eye, zoster is number 3, herpes 1 and 2, Epstein-Barr, and then the cytomegalovirus. And it's the leading cause of corneal blindness, not in third world countries, but in the world. So it's the leading cause of corneal vision loss. Now, what does that mean? That means like if you get a scar or some type of irregular stigmatism from this condition, it can cause you not to see 20/20. So cornea blindness, cornea vision loss, it's the one of the leading causes. And there's an infectious part and a stromal part that we'll talk about. There's an endothelial side and a neurotrophic keratopathy side. That's for a whole other lecture. We're going to focus more on the orals today. Now, with that said, I'm going to open up polling question number 2 here. And polling question number 2 is how much of the total power of the eye is contributed to the cornea? Oops, and it doesn't look like number 2 question got entered. That's my fault. So
Number 2,
what?
what's the flow or fluid? That's in there, Greg.
Oh, is it? Can you open it, Joe?
People are already voting on it, so it must be
Oh,
open.
okay. Okay. Maybe I clicked on it by accident.
Zoom's quirky.
If you could see it, Joe, I'm gonna let you run the polls if you got them. So,
I can do that for you.
all right. Here, I'm gonna open it. I see it. I see it now.
Oh,
It's open.
the first part.
It's all open now. I see
Now it
it.
is, yeah.
Yep. All right. What is the flow of fluid through the cornea? Front to back or back to front? That's part 2. Kind of a weird question, but take a pick if you're not sure. I didn't give you the I don't know, and that's why I'm here option. And then what is the total power? How much of the total power of the cornea contributes to the power of the eye? 30%, 50%, 70%, 90%, 100, and you don't know, and that's why you're here. We're going to be talking a lot of cornea today, and these are some of the concepts I just like to point out. And it looks like the majority of the people are getting the answer. Maybe I've brought it up before, and people are doing the math out there, is that if you think of the total power of the eye being 60, most Ks are 44. So just say 40 over 60, 2/3 of the power, 66%, 70% is the number that I was going for, and I'll display that. We have 35% saying 30, we have 13% saying 50. We got the majority of phoning a friend there, 43%. And that's the number I would go with. Again, 40 over 60 Remember, total power, Ks are 40. So maybe a little bit more than that. So we'll just say 70% of it comes from the cornea. So that's why it doesn't take much power or much problems with the cornea to create vision loss, right? Ocular surface disease, an unhappy cornea. So if you have some issues, always think of that cornea. And then we're kind of split here, front to back, back to front. Well, I'm going to kind of show everyone that the answer that I was going for, again, it's a quirky question, is front to back. And I'll explain that here in the next slide. So I'm just going to close those up and let's jump in. So here's a couple herpes infections and a trauma. We'll get to this person when we get to the analgesics part of the talk, but you can see that we have a dendrite here, and we have two dendrites here and two dendrites here. But this one, you can see I put the sodium fluorescein in. Where I'm going with that front to back part is, let's say, Joe rarely calls me during the day. He'll text me during the day, but rarely calls. But when he calls, I typically pick up. And let's say I put the sodium fluorescein in this eye or this eye here or this eye here, and I picked up on the call. Well, you can see this one over here was basically a patient that was this time of year, April in my area. People are changing tires from the winter, things get corroded. And this guy took a screwdriver, was trying to pry a brake off or something. Boom, went up into his eye. The cornea did what it was supposed to do. It stopped it from penetrating. It went up under his eyelid. He had a laceration. You can see his hyphae, his pupils disrupted. But I put sodium fluorescein in, and the endothelial cell's job is to keep the cornea detergest. So when the epithelium is broken, I didn't put that in my question, but when the epithelium is broken, the flow is from front to back, meaning that the cornea becomes like a vacuum cleaner. If I had a vacuum cleaner in my hand and I could go suck up dirt, it's pulling the suction is pulling things in. If I put my hand over it, nothing can get in. That's how the epithelium works. Look at this. As soon as I put that sodium fluorescein in this big wound, you could see how the endothelial cells have pulled that into the stroma. You could see here, when I was talking about Joe, if he'd call me, I put the sodium fluorescein in. You could see in these pictures here, here's the break, but it's being pulled into the stroma. The epithelium is super, super important. The importance of the epithelium, this is from my neurotrophic keratitis lecture. You can see all these wounds. You can see here that even in this sodium fluorescein and these bigger ones is being pulled. It's being pulled into the stroma. The epithelium, that's why whenever, if I'd ask you in meibomian gland dysfunction, where does that marginal ulcer form? When someone has meibomian gland dysfunction, they have that soap, that frothy tear sitting on their lid margin. It usually is right here, right? Because that soap sits on that cornea, breaks down the epithelium, and then the endothelial cells do what they're supposed to do and starts pulling things in from the tear film, and then they get that immune reaction. So this cornea here, when it's wide open like this in this neurotrophic keratitis, it's just open because the vacuum is on. It's pulling things from front to back into that stroma, and it's open wounds. So we want to point out there that the epithelium is important and that the endothelial cells pull things in. And that now kind of explains what a little bit happens whenever we have a person that comes in like this. This is a 73-year-old woman. It's Tuesday. The dates are just so you can see how long it's been, which is October 22nd, 2022. Doesn't really matter in the year. It's just to show you that on Friday, this is when it occurs. So she comes into me 4 days later. The chief complaint is the right eye possible tear duct. It's itchy on the inner part of the eye, and it was referred by the primary care doc, thinks a clogged tear duct or potentially an infection. And again, it started on Friday. It started to bother the patient. Patient did some Visine, right? Typical Visine, right out of the chart. Little to no help taking cardizem, Eliquest, and Trelegy and albuterol. You can see here now that the cornea vision is down, right? Or the visual acuity is down, and it's most likely going to be from that cornea because obviously we focused on that at the beginning, and we have 20/30 vision. And the IOP is a little bit less in this eye. So let's take a look at our patient here. And our patient, as we use a video here, we went from the white light, and there's your cobalt blue. And I want to point that out. I'm going to go back just a little bit here. Watch what happens. Cobalt blue and turning on a Ratten filter. If you can ever get a slit lamp that has a Ratten filter, or you can get these little filters, some of the contact lens companies have them, they'll hand them out, and you can put them in front of the objective, or the subjective side, I guess, where the subject is sitting. You can just see how it just makes that sodium fluorescent. It just gets the right wavelength. So this is a patient that is herpes simplex. You know, you can say 1, 2, 3, 4, 5, 6. There was one up there, 7. You know, it's potentially, 7 dendrites. And the issue was is that this has been sitting here kind of smoldering for a couple days. I focused in on that one because it almost looks like a reindeer. It's kind of my Christmas virus here. But you could see dendrites. There was a few dendrites across this cornea. If I go back, when we play this, you can see right here the dendritic side of this disease here. So that leads us, Joe, if you want to do polling question number 3, there
Surely.
is
Let me just do that for you.
ocular simplex keratitis, or zoster. Where does this virus hang out before the outbreak? Is it in the B cells, T cells, or the lymphocyte, T lymphocytes? Is it in the monocytes, or is it hanging out in the neurons? Where does this virus like to hang out?
And, Greg, I just saw a patient with simplex. He had 9 dendrites across his cornea. Now, the question, that people may wonder is why do these things smolder? Why does it take so long? Well, the patient is hypostatic. They lose corneal sensation. So it's not a frankly painful disease. It's usually more of an irritation than anything. And that's why they're self-treating, and they're a little bit on the slower side to come in.
It looks like the audience has nailed the question, so they're doing well with it.
I had an interesting patient some little bit ago, Greg. It was a post-op patient, fresh post-op, probably 1 or 2 days post-op, maybe 3 days, cataract surgery, and had a dendrite that broke out after cataract surgery, probably from the stress of cataract surgery. And of course, that person needed to be on steroids, for
Right.
the post-op inflammation. The question is, what do you do? And I'm sure you're going to be talking about the orals, but an oral Valtrex work beautifully, even in the face of steroid use.
Yep, it usually does. All right, let me display it. We have the majority of the people winning this one here. It's 78% going neuronal and a handful going after the monocytes, T cells, and B cells. So again, here are these 8 viruses that affect the bot or affect humans. And then where I was going with in the latency part, where do they hang out? And obviously, that's why they have that dendritic pattern. They live in the neurons. And when they come out on the eye, it's the trigeminal nerve. And that's why you get that epithelial type of, mucosal epithelial type of outbreak when it happens. The Epstein-Barr is the B cells, and the monocytes would be your cytomegalovirus. And that's why when you maybe a patient with HIV or AIDS, they get the vitritis because it's coming in through the monocytes and the lymphocytes. So neuronal, obviously, here for simplex and zoster. Now here's our patient that came in. I'm going to play it. And Joe, just let me know if you can hear this. I think I hooked up the sound whenever I connected.
All right, everyone. I'm here with Helen. As you can see, she's got a nice, Christmas tree red right eyeball. I was examining her, and we got a diagnosis here of herpes simplex. And I was explaining to Helen that this is a cold sore virus. They can come out in different places because of the trigeminal nerve. And she was a little bit ill last week. And Helen, just kind of tell me what you just pointed and told me about what happened last week.
I had a virus last week, and they tested me for the COVID and for the flu. Neither one of those, they were good. And then I woke up. That was on a Friday. I think I woke up, and then I had sores in both nose. Of course, when you pick them, they bleed, and they still stay there. And then one under my nose. But other than that, I mean, no cold sores or anything.
Right. So, and I'll pull up here on the computer here in a little bit, but this virus is a neuronal virus, which means it lives in the nerves. So that's why it's all kind of contained. And when I show you this pattern, you're going to see why it was your nose and why it was your eye when I show you this pattern. Okay. But we got it. We just got to get you on. I'll get you on Valtrex. I'll probably do 1,000 milligrams 3 times a day. We'll watch it closely, and then once it starts to reverse, I'll put you on some steroids to cut back on the scarring. Okay. All right.
And Joe, that's exactly what happened with this patient. If you want to open up polling question number 4, there's only 8 polling questions, so we'll get through a front end of them here, and then we'll get into the meat of it. But that's what happened with her. I mean, she had 7 dendrites on her, and why isn't she coming in? Because the trigeminal nerve gives feeling. It kind of blocks that sensation, and then it allows, like you said, these people to self-treat and don't know the seriousness of it. So.
Yeah, in fact, when patients come in, they said they have this irritation, kind of it's not really painful, but irritated, and that's really to me a signal to consider this.
So I opened up the question here: is this infectious or inflammatory? That goes to the picture up top. Is that infectious or inflammatory? And then the question is, do you need topical antivirals, Veroptic or Zirgan, for most of the HSV cases that are out there? So is this infectious when you see this pattern, inflammatory? And do you need a topical?
Or maybe we should say, is it primarily infectious or primarily inflammatory? I'll let you change your answers if you want to do that. Okay, Greg, I think we are slowing down a little bit.
Good. So I'll display it. I'll do the first inflammatory infectious, and it's split right here, and that's why we want to do it. And when you see this dendrite that's coming through here, this is the infectious part of the disease. Right here is the dendrite. There's another dendrite down here. It lives in the neuron. It's, for whatever reason, the stress on the body is allowing it to come out, and then you have bug here. Now, your immune system's going to recognize it, but obviously your immune system could not contain it. In this case, you could do Zirgan, trifluridine, Veroptic, or we're going to talk about an oral tonight on this, and you're going to kill the bug. Now, that was my whole importance. Why is it front to back or back to front? Because when you kill the bug, that's not the end of the story, right? I always, use a gross analogy is that, I drive to work every day and it's about a 12 miles and it's in the rural area. And unfortunately, animals do not make it across the road, whether it's deer or possum or some type of animal. And when you drive by, then the coyotes come out and the crows come out and it eventually disappears. When you kill the bug or your immune system kills the bug, that's not the end of the story. And more importantly, because of the endothelial cells and that bug is going through the neuron, has opened up the cornea, and then you're going to kill it with an anti-infective, the bug gets pulled into the stroma. So it's infectious as epithelial, inflammatory usually a reaction when it gets into the stroma. Now think about if that dead bug gets pulled into the anterior chamber. If it gets in the anterior chamber, then there's going to be an immune reaction, and that's how an iritis can occur. So basically, this is infectious or primarily infectious, as Joe said. We're going to use tonight's lecture to kill this bug, but then we're going to have to deal with the body reacting. That's what happens when we get a cold. That's what happened with COVID. Our body recognized the COVID, killed the COVID virus. That really wasn't the end of it. We had all that we had that new protein in our body, and our body had to react to that. And then we all knew that that was all over the place, to sniffles, to some people, so some people dying. And then, do we need to have a topical on all these cases? And so I'm going to close this one. I'm going to close the display and then display this one here. And majority, 60% said no, or said no, and 40% said yes. So we'll go through the talk here. And I'm going to tell you, I'm not sure the last time I did a topical Zirgan on a herpes simplex. I can tell you though, if I had one like this over the visual axis, I'd like to do something else. And that could be an amniotic membrane. That could be Zirgan along with the oral medication. So let's go on. So this is that same patient. Remember, she had 7 lesions. We're going to educate her on her finding. She came in. She thought she had a blocked nose, tear duct. You know, we photo and video documented this. And I went with 1,000 milligrams 3 times a day. Watch her closely. She had that central dendrite. She had 7 dendrites. I said, how about we do a Procara? I had my office manager call. She had a large deductible. She still had $1,500 to be a part of that. She declined it, even though she was already through most of the year. She wasn't going to close it out. So maybe she made the option of, okay, doc, we'll use it if you feel it, but let's go without it. And then I made a note in the chart because I travel so much that add steroid at the sign of reversal. She had 7 dendrites, big dendrites. I know there's a lot of bug on this cornea. She's probably going to react. So add a steroid at the sign of reversal. So basically, all she gets is oral Valtrex on day 1 and a quick follow-up. So here she comes back a day later and she feels slightly better. Her vision has improved 1 line. She's already taking 3 1,000 milligrams yesterday and 2 today. So the question comes down to, because it was a 60-40 split, can you get away with herpes simplex? Can you get away with just orals? And there's a lot of evidence-based medicine out there. This is 2016 when these started, and they just keep coming out year after year. You can look it up, go to PubMed, you can do a Google Scholar, and you'll see that there's plenty of evidence out there that you can go oral only. But my pearl is when it's something over that visual axis, I always like to do something else, and that's just a personal little twist on it. And again, oral acyclovir alone appeared to be as effective as topical antivirals. And again, there's literature, and this is going back all the way to 2010 that's out there. So well over a decade of using just orals for these patients. So with that said, she was okay. She didn't want to pay for the Procara. I said, well, with that comes a close follow-up. We'll see it tomorrow. Here's her video presentation. You can see the eye is less red. That's just with white light there, zooming in on that remember that one that was a rainbow lesion. Now remember what we're doing. We were using an antiviral here to kill the virus. Okay, that story's not over whenever that virus is dead. It's a foreign protein. Here it is now with the Ratten filter and some sodium fluorescein. We could see the dendrite here. We have a dendrite up here. And then there was one right there, right along that limbal margin. And so lots of bug on here. Glad we're using an oral here. And you can see I went with the big strength there. There's a lot of simplex out there. A lot of people will say 500 milligrams 3 times a day is enough. This is a very safe medication. So I typically, because I know it's a safe medication, I've lectured on it, researched on it. This body's having a tough time struggling keeping this virus under control. So I decided I'd just do 1,000 milligrams 3 times a day by mouth. So 1-day follow-up, it's improving. Continue that Valtrex, watch closely. We photo documented, and again, made a note in the chart to add steroids when reversed, come back in 2 days. So she comes back in day 3 now. It's the 22nd that I saw her. It started on the 18th. It's now the 25th. And she reports her eyes, watering over the last 2 days. That's good sign to me because remember, when that neuron is blocked, that trigeminal nerve, it's not giving some feeling. So to me, it's kind of showing that this eye is irritated now. So I like that she reports that the eye is watering. The patient is taking her Valtrex as prescribed. Her vision is still 20/70, and that pressure is still low in the eye. She probably got a little inflammatory reaction going on. But you can see here that this eye was a lot red. The skin was red, and her eye is less red here just 2 to 3 days just 3 days after starting this. So, Joe, if you can watch the chat box, I didn't make this a polling question. We had enough going on with it. Just, is it time for the steroid? We're at day 3 here. Would we add the steroid? I'm going to play the videos as the chat box goes on. Here's the white light, just using Valtrex. We had about 7 dendrites. You can see the eye is less red. And we'll play this video here. And we'll pull that lid, have them look down hopefully here and pull that lid up so we can see what's going on. There's that one ray here. Here's the other ones here. There was the reindeer one right there. Is it time for the steroid or is it too early? What are your thoughts out there? Time for the steroid or too early?
Well, everybody so far who's weighed in on that question has said yes, but there
Okay.
were a couple other questions that also came in prior, so let's go over those. One question is, how many days of Valtrex do you use?
That's a great question. In this case here, I would do 7 days, 3 times a day. So it's going to be 7 times 3, which would be 21 pills that I would give this patient. So 7 days.
And could you also cycloplegic this patient day 1?
You could cycloplegic. The patient wasn't in much pain. I didn't see much of an anterior chamber reaction. I certainly do not see a reason not to. That's there. You could cycloplegic them to maybe prevent that iritis. But it's not common practice for what I do.
Okay. When would you start a patient on a lower dose than 1,000 3 times a day? Kidney or liver disease consideration?
Yeah, these medications, as we get into the 3 medications, when we get there and talk about them kind of in a rapid style, these ones are cleared through the kidneys. So maybe if there was some kidney disease going on, you could go with a lower dose. They usually adjust it. I'd call the PCP if they had kidney disease. They would use the creatinine clearance to do that. But you know, that would probably be the only time. Most of the time, to me, I think of this is that this. Remember, this is a neuronal virus. It's living in our body. Our immune system should be taking care of it. Some reason the immune system is not. So it sounds like to me the immune system needs help. So I just go with whether it's zoster or simplex, 1,000 milligrams 3. But certainly the simplex is a wimpier virus over the zoster virus. You can get away with 500. But remember how this medication works. When you take a medication, it goes into every cell of the body, whether it's aspirin or your blood pressure medication that's out there, or when you take this Valtrex. The cool thing about it, it's a prodrug. The virus makes a enzyme that activates it, cleaves off a certain part of these medications and activates it within the cell to kill the virus. So if it goes into a cell that doesn't have a virus, the cellular metabolism of it will just kind of the half-life of the medication. It doesn't really do anything in that cell. The cell that has the virus produces the enzyme that cuts off part of the medication, activates it to kill it. So to me, it seems like it needs a little bit of help. So that's why I do 1,000.
Now, did you use that higher dosing because of the number of lesions? And would you do the same dosage even if there is one dendrite? Maybe that was off the visual axis. Would that temper your dosing?
Yep. And again, it's my philosophy, and I'm not saying it's wrong if you want to go 500, but I typically, if I have simplex, to me, that body needs help. It's a neuronal virus. Their immune system needs assistance. So I go with 1,000 milligrams, whether it's 7, 1, that, one dendrite, 7, peripheral or central. I do 1,000 milligrams 3 times a day by mouth.
You're all caught up on the question, and most people would add the steroid at this point. And
Yep,
one
and I
person
agree.
made a comment that they would add the steroid when the rose bengal no longer stained.
Okay, that's a good comment too. This to me is reversal. This eye is now responding well. I've seen it reverse the medication. Now we have that fun part, right? We have the infectious side. Now we want to add the steroid to kind of keep this cornea, which is clear, from scarring. So we added the steroid, and I did a load of prednisone type of product for the patient. So at day 3 here, they're improving, responding to treatment. I want the patient to finish that Valtrex. We're going to start the load of prednisone. And anytime I do that, they need to come back the next day. Oh, the patient is leaving town. So I gave them my cell phone number and we had a chat the next day. And I said, when will you be back? They said, on Monday. And I said, okay, perfect. I will see you Monday. So, we try to put these things in set in stone. I always try to see them the next day. She's leaving town. She's leaving early in the morning, like 2 o'clock in the morning, because I would have gone in and maybe see them before they left. 5 o'clock, 6 o'clock, but she's out and about and gone, and so they get my cell phone number and we get to chat over the weekend. So she comes in on that Monday. She reports her improvement since the last visit. The eye, some watering. The vision is still 20/70. Now she has a cataract in this eye. I think eventually she gets down to about 20/30. But again, all those dendrites, a little bit of swelling, 70%. It doesn't take much of that cornea being sick to cause that vision to drop. Good sign here. The IOP has come up. Now, I don't think that's steroid responding. I think they had a little bit of an iritis, a little bit of inflammation. She was delayed getting in. Some of that bug probably got pulled into the anterior chamber, and then we're starting to see the inflammation go away. So here she is here at time 0, or the day after that I saw her on the 22nd, then the 23rd, and then here she is. The eye looks really, really quiet. Some of these lesions maybe around the eye, some of this redness is starting to clear up. She's responding well. So here she is at day 6. She's on her orals. She's on her topicals. We didn't thin her out. We didn't melt her cornea. And now hopefully what we're doing is preventing the inflammatory reaction from occurring. So I'm just smearing some of the fluorescein there to get a good, and now you can see the power of the Ratten filter there. And then here's just a picture. This is not a video. The cornea looks nice and clear.
Greg, an interesting question came in. What would be the next step if at 48, 72 hours on treatment, oral treatment, there's no improvement, or the dendrites appear to be worsening? What do you consider? What do you do then?
Yeah, that's a great question. I'd probably add a topical at this point. There could be, poor compliance. Maybe they got some gut issues. Maybe it's not absorbing. You'd have to, reach for your trifluoridine, your Zirgan, and, go with maybe an amniotic membrane at that point to help with the inflammatory side, and then hit it from the topical side with it's these medications. That's why it's 1,000 milligrams. They're big pills that you have to give a lot of because they don't absorb well through the gut lining. So I'd go topical. I definitely add a topical.
Greg, I think in a situation, this is kind of almost a theoretical, because the orals work so well. So my approach or thought process would be, number one, is the diagnosis correct? Is it a pseudodendrite and something else, or is it a true dendrite? 2, are they immunosuppressed? That's why it's getting worse.
Yeah, definitely. All
But
options.
but
Absolutely.
frankly, these just work so well. I mean, it's on the level, I guess you can say, of Xdemvy for Demodex. You put it in, it almost is guaranteed to work.
Yeah, I agree. Yeah, and those are some good points that you brought up. The immunosuppressed, or are they literally swallowing them, or are they missing their mouth? I guess, but the option would be you go topical with it too. So here, that was day 6 again, 7 dendrites improving, corneal haze, all the fun stuff, recheck in 1 week. The key is I had them stay on, finished out their Valtrex and kept them on their loteprednol 4 times a day. At day 13 here, we finished the Valtrex. She's on the loteprednol. Her visual acuity is 20/60, and she's got 14 as pressures. This seems to be coming out of the woods. Here's what she looks like at day 13. A little bit of haze there. I'm glad we got the steroid on board when we did. You can see the cataract in the background there. She needs to get some cataract surgery. So she's healing up nicely, and this was a topical steroid and orals only. At day 13, I said, okay, you're doing well. Let's use the loteprednol because I know that there's a lot of bug in there. She had 7 dendrites. Just use it twice a day until the bottle's empty. Let's consider that cataract surgery, and we'll see you back in a month. So Valtrex and loteprednol are finished. She's 20/40 now, so a lot of that swelling is cleared up. She's limited by again, it's at 70% and didn't take much. She was 20/80, 20/70, 20/60. Slowly, that cornea had, in a sense, a remodel. Minimal haze, no iritis. She has a little bit of a nasal ectropy on here. We're going to refer for cataract surgery, but the question is, polling question number 5 is, and I can get it open. I have it right here. Would you start a maintenance dose of Valtrex at this point? So remember, she had 7 dendrites. She had a sick cornea. Would you start the 500 milligrams once a day? Yes, no. First outbreak that we're aware of.
Now, here's another question, and I think we can probably both weigh in. Loteprednol is very expensive in Audrey's experience. Is it necessary? Can you use another steroid?
Oh, it's certainly not necessary. You can go with prednisolone if that's your concern. I'm not sure if FML and all the Durazols that are out there, but you definitely go prednisolone. I wouldn't have a problem with that. To me, there's a lot of generic loteprednols that are out there. You can, Lotemax SM if you want. They have these different coupons that are out there for the patient if you want to go through that. But certainly you can go with a prednisolone if you want.
Yeah, and these generics, they go up and down in price. They're not always cheap. Audrey is right, and a lot of it depends on the patient's coverage. I've seen the loteprednols come back fully covered, and come back at a very outrageous price. So I do like Durazol. It's generic now, and honestly, because there's so few manufacturers, sometimes when you write a generic Durazol, you're getting the brand Durazol, and it's actually pretty well covered. So I've been happy with that. And Pred is always a great go-to, though.
So let's display the answer here, and we got 55 majority going with a maintenance. Now I'm not sure if because we're sending them for cataract surgery, if we're going to lean that way, but majority of the time, the patients, if I would say to them, hey, I'm going to put you on Valtrex, 500 milligrams. There's the herpetic eye disease study. It's really not recurrent at this point. Most of the patients, from my experience, are not. It's a good thing to consider because you're going to send them for cataract surgery. Maybe your surgeon would like that, but I don't see that there's a necessary reason to start them on a maintenance dose and put them on a chronic medication that gets cleared through the kidney. And we'll get back to that here very shortly with the case. I want to show you a really quick anterior segment quick tip. Here's a dendrite right here, and sometimes you're wondering if they're thinning and what's going on. So don't forget, you can take, and I have a great technician, a couple great technicians, but Sarah typically works with me, and you can see here that she's taken a line of the anterior segment, and you can see how the cornea is swollen. You can see the infection right here. You can see the swelling that's occurring to this cornea. And the reason why I do this sometimes is that I want to make sure I'm not causing a stromal thinning. Now, don't forget, when you put the steroid on, the swelling will go down. Just what you're looking for is more of a melt that's out there. So this was just a patient that came in that had this dendrite. This is a totally different person. And what I did, again, Valtrex, 1,000 milligrams, 3 times a day by mouth, and decided just to kind of show off with the OCT there. Now, pregnancy categories, this is going to be for any type of oral medication that's out there, or any type of pharmaceutical. Back in the old day, there was category A and B, then C, D, and then X, and X sounded bad. This is the old category. Pretty much everything is done category C because we're not going to do studies on pregnant ladies. So that's why if someone doesn't know they're pregnant and they're on a medication, they should report it, especially as depending on what trimester they're in, first, second, or third. That's where a lot of this stuff comes from because, again, it's a little bit, not right, inhumane to do, studies on, hey, we're going to use we're going to use you and your child to see if there's going to be a birth defect, right? So that's just not right. But there are people that don't realize they're pregnant and they're on medications, and that's where that comes from. That's why a lot of them are C. But sometimes there's animal studies and enough studies out there to claim it A or B. To me, that's no risk or safe. C, depending on where we are, you might want to avoid. D and X, that really comes down to kind of life or death of the fetus and the patient, or say maybe blindness, and that would be a tough decision to decide on if you're going to use a medication. So basically, the categories are A, B, C, D, and X. C, I would avoid. D for sure, and X avoid. A and B, it's safe. Then in 2014, there was a new ruling. That's why you see these new package inserts that are out there. And what you're looking for on the package insert is that 8.1, and we'll talk about pregnancy. 8.2, we'll talk about lactation. And 8.3 talks about the reproductive potentials. Now, it doesn't have to be on there if if there's no data to report, then they're allowed to admit it. So sometimes you'll see a package insert or a product insert that will say 8.1, nothing on 8.2, then 8.3 or any of them, vice versa. They could be missing if there's no data that's out there. So what I want to point out here, this is the product insert or the package insert for Valtrex. It was out before June 30th. So if you just jump down, now they do a hybrid. They do the 8.1, but you do see here that it's category B. So this is really cool. Someone comes in and they're pregnant. Obviously, we want to use as least amount of medications if the patient is pregnant, but this one's listed as category B, again, because it goes into the cells and only activates in the cells that have the virus. So category B for Valtrex, and you'll see here that there's nothing on 8.2 to report, but on 8.3, the nursing mothers here, there is something to report. And then this is just Xiidra. The reason why I picked this was it came out after June 30th. And what I would point out again is if you go to, again, the 8, it has 8.1, 8.2, and no 8.3. So you would jump, but you're not going to see category A, B, C because it came after. It's going to talk about, the clinical data here. So it's see right here, if you look at it says pregnancy, it doesn't say A, B, or C, and it's just going to say that there's no clinical data on it. That's why if someone's ever pregnant, you should probably have them report it and see if they can be entered. Now, here is a quick overview of these medications. Acyclovir, it is the drug. Remember, Valtrex is the prodrug. So there's acyclovir, and then there's valcyclovir and Famvir. Famvir is really not used much, but we used to use a lot of acyclovir before Valtrex went generic. Basically 800 milligrams 5 times a day, which is 4 grams. And again, that's because it's poorly absorbed. You could do a maintenance of 400 milligrams twice a day. These are all cleared through the kidney, and they're all category B in the orals. When it comes to topical, they're category C. So we're not going to do topicals tonight, but we'll talk about the orals. And, we're going to use Valtrex and Famvir off-label because they're approved for genital herpes. That's okay because corneal specialists and a lot of articles out there that support using, even though there's not an on-label study, off-label is okay if it's the standard of care. You're not going to find it in the PDR being referenced like you will acyclovir for ocular herpes simplex or zoster. but it's okay to use this off-label. We do it all the time when we use a fourth generation fluoroquinolone to treat a bacteria keratitis. It's approved for just conjunctivitis, but it's what everyone does. It's the standard of care. Famvir, that's your other one of the orals in here. I'll just kind of just click through, point out again, it's through the kidney. It is category B. It's no longer available as a brand anymore. It's all generic. And we talked about Valtrex. It's the prodrug of acyclovir. You can see it right here, Val-acyclovir. I like it. It's a gram less. It's 1,000 milligrams 3 times a day. It's good for herpes simplex 1, 2, and zoster. And the dosage, again, you could do 500 milligrams in some of these cases 3 times a day, or you could do what we've been talking about, maximum dose 1,000 milligrams 3 times a week, 3 times a day by mouth for a week. Again, kidney, kidney, kidney. That's important when we get to the case of recurrence. And then we have category B. Now, besides all those differences, the number one dropout for people in the head study, the herpetic eye disease study, was GI side effect. That was the number one reason people stopped from being in that study. So they had a lot of GI symptoms. And Dr. Offerdahl, Tracy Offerdahl, a pharmacist, we were looking at the labels because she was teaching me some pharmacology. She goes, let's look at the inactive ingredients. And you can see here that the inactive ingredients of acyclovir and famvir have lactose. And there's a lot of lactose intolerant people out there. And you can see here, Valtrex does not have it. When I asked what was your go-to, again, it's a prodrug of acyclovir. It's hard to maybe sometimes get famvir. And now this one is lactose free. Even the generics are lactose free. So again, maybe leaning, there was 50-some% that liked Valtrex, lean the other way here, maybe those that are out there not claiming superiority, but just trying to help you out with why we use some of the medications in clinic. These are all cleared through the kidneys. Again, if they have kidney disease, the primary care doc, the internist will help you adjust the dosage based upon their creatinine clearance. They go into every cell of the body. We talked about that a little bit earlier. There was back in the day, they were worried about being cancerous. That was the first generation. We're already on the third generation, and it's really cool how that drug works. It goes into the cell, activates only in the cell that has the virus. So you can use them prophylactically for PRK and LASIK and PT, and in this case where I had the lady, maybe for cataract surgery. Now, here are the ocular findings of basically of zoster, but could be of any of the herpes virus. You can get an episcleritis, scleritis, SPK, a pseudodendrite, stromal keratitis, uveitis, glaucoma, vitritis, retinitis, optic neuritis, and palsies. This is why, if you ever wondered, why did the PCP have someone that comes in with zoster, so we're going to talk about next, zoster, and they started on maybe on an oral steroid. They started them on 1,000 milligrams of zoster because they were trained that, I'm not going to read the list to you, that episcleritis, scleritis, vitritis, retinitis, neuritis, optic neuritis can happen. You can see down here, here's the retinitis. So they want to dilate and examine a report back when these herpes zoster patients come in. And when that tip of the nose is involved, the eye could be involved. That's a high sign that that virus has made it out to here, that they could have made it to the globe. So I mean that a lot of times when we see zoster patients, it's just skin. But when that tip of the nose is involved, usually at times you have to be concerned about the globe. And then this is what they were taught in what could happen. So they want a good exam. So the varicella zoster virus, the chickenpox virus, in adults, it's the shingles virus. You can see again, it follows the neurons. It's a neuronal virus. Here's a patient here that came in. You can see her eye is involved. Maybe this part of the nose, and her eye is red. We treated her well over time here, and she did well. We're going to skip the video in time here. I want to get into some of the other meds. Here is a patient that had, you can see the neuronal side of it. He was bald. You could see how red and inflamed he is. And that's why sometimes we'll start some oral steroids to help some of these patients that are out there. And some literature says it can help with post-herpetic neuralgia. This was a guy that came in. I said, "Ooh, it looks like zoster." I touched it with my finger or cotton tip applicator versus the other side of the nose. He didn't really feel it real well. This really wasn't painful. Slightly irritated, to use what Joe said. We put him on Valtrex, and here's the size of them. When this came in, this is actually not his hand. This is another patient of mine. They brought in the Valtrex. Look how big these pills are. They're huge. It doesn't absorb well, these oral medications, and that's why you do 1,000 milligrams 3 times a day. But let me go back. We used the Valtrex. There's what he looked like. And then we came in. There's what we did. We're killing that bug, and I can see more of that dendritic appearance. And look, the end of his nose, but his eye was spared on that. Here's when you want to.
Greg,
Go ahead, Joe.
just a quick thing that I see, and this is a misconception of the patients, the primary care physicians, the patient's family. They come in and we get that referral and they're already on treatment. They want us to look. And they always say, it's getting real close to my eye. I'm worried about it getting in my eye. And I try to explain to them, as you did, it's the tip of the nose that's more important. And that if it's there, it's more likely to be in the eye. And it's not like it's a creeping crud that's going to move into the eye. By the time I see you either have it in the eye or you don't.
And again, that's why I go back and talk about neuronal, right? I mean, for that helps me out to explain to the patient, hey, look, this lives in your neuron. It's not going to come out, and then you're going to kind of spread it. Now, if that division of that neuron, if it decides to make that turn, it can come out into your eye. I explain them, it's like the electricity in your house, it's wired. And that's why I press upon some of these concepts tonight to our audience, is that it's neuronal, and that might help you to remember, just like you said, if they rub it, it's touch their eye, there's probably not enough active virus to transmit it over to the create a conjunctivitis. So yeah, you're right. Any other comments, questions?
Let's see. I think nope, we're all caught up in questions.
Okay. So again, this is the zoster virus. I really wasn't sure what this was until I pushed the slit lamp away. She had this kind of swelling. She had this kind of tingling feeling. And then when I pushed her hair away, I thought this was really, really cool. I'm like, oh, I know what you got now. Look at this almost dendritic appearance, but she has herpes zoster. This is a herpes zoster outbreak coming in this. You can see the redness here, and you can see the swelling down here, but you can see this was pretty cool. That's what gave me the diagnosis. And we put her on 1,000 milligrams again of the Valtrex 3 times a day. Let me go through this case real quick, because again, I want to make sure I get into some of the other medications. This is this is how it typically works for the patients that go on the maintenance dose. This was a 37-year-old woman that came in. You could see here, everything looks good. She has her first outbreak. So we already know what we're going to do here with this. The treatment's going to be 1,000 milligrams 3 times a day by mouth. We're going to wait for some reversal, probably add the steroid because it's a central location here. We're going to have, it's a big dendrite. There's a lot of bug. It's going to get sucked into the stroma, maybe the anterior chamber. Are we going to do a maintenance? This is the first episode. You could talk to the patient about it, because once you resolve this, the herpetic eye disease study said once you get it the first time and you're trying to the chance of it coming back within a year is 1 out of 4. This is why a lot of patients do not go on it. When you have your first episode and you clear it, that's what happened here. Here's the patient here. We cleared it. I tell them there's not too many percentage. I said, look, there's a 25% chance, or 1 in 4 of my patients are going to come back. Do you want to go on it? The answer is usually no. And that's just documented in the chart. Her reviewed the herpetic eye disease study, 25% patient declined. Okay. Now, I just always like to point this out. Topicals just beat the heck out of the eye, especially trifluridine. That's why we try and use Zirgan, but then it's not covered. It just creates a toxic keratitis, all the staining. And if you're going to go topical, try to use Zirgan. It's a little bit more effective, and it's less toxic to the cornea. Now, this patient, I told her it was a 1 in 4 chance of it coming back. She comes back 5 months later. Okay, now we're sitting and we're going to do the same thing. We're going to educate the patient, but this time we're going to tell them it's a 43% chance. It was 25% within a year. Now you're back within the year. The herpetic eye disease study said it's going to be a 43% chance of this coming back. Okay, doc, you cleared this for me the one time. I really don't want to go on. The ones that go on, I'll tell you who they are. It's usually the patients that have cold sores, the nose sore. They usually, I could say, look, I got a deal for you. I got to treat your eye, and we're going to try and prevent these from coming back. But most likely, it's going to also treat those cold sores of your lip. All right, so if they're a cold sore sufferer, they'll probably go on. And I have that discussion with them. I said, look, I just can't just have it stop at your eye and you might get a little benefit from it. But most of them do decline. Now, this is the third time that it has come back, right? So what's going to happen? How are we going to treat this person? Short term, reduce the viral load. Again, I did it the other 2 times for this patient, 1,000 milligrams by mouth 3 times a day. Clear this out, use the load of prednisone. Then going forward will be 500 milligrams of Valtrex once a day. And that will be for the maintenance dose that's out there. So that's typically how those go. When I see these patients, it's usually the third time that it's come back, maybe the second time if they're cold sore sufferers or in their nose or in the roof of their mouth. I have a deal for you. But most of the time, it starts to become recurrent. There's something going on with their immune system. It needs a little support. Reduce the virus in their body, 1,000 milligrams 3 times a day by mouth. Once it's all cleared up, like way back here, once we get to time 0, then we can now go for 500 milligrams once a day. All right, that's a lot of herpes and Valtrex and all the different medications. Joe, are there any questions while I do this polling question? What I want to know
Well,
out
yes, there
there
is.
let me do this. Do you have a DEA license? And then have you prescribed a narcotic in the last 24 months?
2 questions just came in. Do you ever recommend lysine daily to decrease the frequency of the herpes outbreak?
The answer is yes. There's a lot of studies out there. I go a little bit more. This will be my functional medicine. I wasn't going to do much of it, but since that question came in, L-lysine is a part of is a part of is an amino acid, and it helps support the immune system. What I try to do is I just kind of go a little bit more comprehensive. I think if you've heard me speak over the last few years, Joe has certainly heard it enough times, is that I would probably, instead of doing L-lysine, I would probably put them on fish oil and a more comprehensive type of supplement from A to Z, polyphenols, flavonoids, carotenoids. But I used to do that. Now I go a little bit more comprehensive. I do like the natural approach. What you're trying to do with that is support the immune system. You're not really killing the virus. You're trying to keep that immune system robust so that you can help prevent these from coming back.
Now here's a question. 43% chance recurrence from the first outbreak to 12 months, or a 43% chance of recurrence in the next 12 months?
Yeah, within the next 12 months. So when they get their first one, then there's a 25% chance they're going to be back. Then they get the second outbreak, there's a 43% chance that they'll be back in the next 12 months.
Mm-hmm. And how long do you keep on the maintenance dose?
Yeah, that's the $1 million question. If you do the follow-up from the herpetic eye disease study, because eventually the fund runs out and the study ends, but there's people that are in it. I read a little blip. This was now probably going on 8 to 10 years ago. Oh, there's some outcome from the herpetic eye disease. What to do after a year? It basically said, oh, there's a benefit if they stay on it. Wasn't really rocket science. Here's what happens in my case. After a year, and we know these things are cleared through the kidneys, if they are a herpetic cold sore sufferer and they're doing well, they usually want to stay on it. If they're not a herpetic cold sore sufferer, after the 6 to 12 months, we try maybe going every other day and then getting them off of it. But really, you can keep them on for a lifetime. Just make sure you get the kidneys checked because they're cleared through the kidneys. That doesn't mean I have to do it. That's just a simple, hey, Joe Saka, primary care doctor, Greg Caldwell, this patient is taking 500 milligrams. We do know these are cleared through the kidneys. Please monitor their kidney function. So it's not me doing it, it's the primary care.
All good.
Okay. So that's great because I see that 40% or 38% have a DEA, and we have 6% that have used it over the course of the year. So let's close that. Let's close that. Let's close that. All right, let's talk. What is your go-to analgesic regimen? Please use the chat box. What's your go-to oral analgesic regimen? Like for this right here, this is a corneal burn. This patient comes in, this patient was curling their hair. Their daughter walks in. They said, what? They didn't move their hand, they moved their head. Now you have well done, hardly red, well done, charred epithelium, patient in a lot of pain. What's your go-to analgesic regimen? And Joe, just keep an eye on that as I go through the presentation. So here's a guy that has come into the office. He thinks, or he was hit in his eye with a tree branch, and his eye really hurts. Now, after taking a look at him, I pulled up, let me just go here. I pulled up a pain scale. I don't have them hanging in my office like a hospital. I could just go combination pain scale, go to Google, hit images, and one of them will pop up. This is the one I like. I like it because it's got green, the red, it's got smiley faces, the sad faces, it's got verbal descriptions. So, because when I looked into his eye and I saw this, I said, okay, what's your pain scale? Because your eye really hurts. He said 7 out of 10. And whenever I got my little spud down here and pulled this conjunctival laceration away, you could see he had a thorn that went into the eye. The sclera did what it was supposed to do. I dilated him. I looked. He had no sidels, no retinal pathology. It did not penetrate. He has a conjunctival laceration, a big hemorrhage there, and probably a little trauma to his sclera. And that's why he's got a 7 out of 10. All right, we used the pain scale. He healed well with the regimen. We used some pain medication on him, which was a narcotic here, which I'm going to talk about. We talked about the curling iron burn. This would be a good time when we're going to use probably more than maybe. Remember, steroids are pain suppressant. That's why dexamethasone in our Maxitrol and Turbidex will help put that out. It helps calm the eye, helps calm the inflammation. Probably need a little bit more than dexamethasone. I'm going to maybe use Turbidex or Maxitrol in this patient, but they're probably going to need with that 7 out of 10 a little bit more help. This one I thought was trying to pull the wool over my eyes. He's like, yeah, I worked with these knives and models, and I cut myself. And I'm like, I'm in a lot of pain, doc. I know I did something. 6 out of 10. And then I looked, and he was telling about these knives that he used for these kind of small models. So then I got my OCT out, and I said, oh yeah, you did a good job. You gave yourself a self-induced kind of RK incision. And whenever I measured it against the cornea, about 600 here, 400 here, he went 2/3 of the way through. And we know that cornea is very innervated with corneal nerves, the most innervated part of our body. So I agree that he was probably a 6 out of 10. And you could see even some of the swelling and inflammation that has already occurred. So he was almost full penetrating with his little self-induced RK incision. We showed this one a little bit earlier. He was prying a brake off his car. Screwdriver hit his eye. You can see the sodium fluorescein. We can see the subconcheme, the hyphema, the misshapen pupil, the laceration. Well, he's a tough guy. He's a 7 out of 10. I'd probably be a 10 out of 10 if that was me. But we treated this person successfully. And then here's a guy that's a 6 out of 10, DSEC procedure. Never went back for follow-ups, kind of forgot, didn't use any drops, didn't use any steroids, and he ended up with an endophthalmitis. He had to go back to Philly, who did the DSEC. Can you give me something, doc, for the ride? Yes, I will, because we're sending you out today. So let's talk about some of the narcotics that are out there. And Joe, I'm curious, did anyone weigh in on their regimen?
A lot of people weighed in. I see NSAID, Advil, 1,000 milligrams Tylenol, alternating with 400 milligrams ibuprofen TID. NSAID, Tylenol with Advil, stagger NSAID and acetaminophen, combination. A lot of things like that. Alternate acetaminophen, ibuprofen. A lot of the non-narcotics are coming up. I don't see anything narcotic. Oh, here's an interesting thing. Oh, this one's unique. Four Fingers Jack Daniel's neat.
Yeah, which Jack Daniels now? Is that Black Jack in Black? Is that Gentleman Jack, or where are we going with that one? So
I think it's Four Fingers Gentleman Jack neat.
there we go. Perfect. All right. All right. Thanks for weighing in, everyone.
But
I'm going to change
in that case, Greg, it's not alcohol, it's medicine.
That's right. In that case, it is not alcohol. So here's what I'm going to just change from some of that. There is literature out there. I hear the alternating of the ibuprofen and Tylenol, and that's a good place to talk about that because they showed when you take 1,000 milligrams of Tylenol, and it could be four, or it could be 4 or 800. It was the 800, so 800 ibuprofen and 1,000 at the same time. It gets to the level of morphine. It just doesn't stay there as long. When you start alternating it, it works. It just doesn't get as high in the pain scale of blocking. So those who are doing that at alternating, I would encourage you just to kind of just tell the patient, and I'll talk about that here shortly. So morphine is the standard that they use. We don't really prescribe morphine, but if you were going to prescribe a medication like Ultram or Lortab, you have to be careful because some are IR, immediate release. Some are continuous release. Continuous relief would be for someone with back pain, and you're just trying to get them enough pain reduction to get them through everyday life. Your immediate release would be to get them to try and get them as comfortable as possible in this acute. So it depends whether it's acute or chronic. Most of us are going to be treating chronic pain as these curling iron burns, sticking screwdrivers in your eye, not getting follow up and getting endophthalmitis, and so on and so forth. Here is the go-to if you really want to use that DEA license, and this is a really safe medication. It's tramadol. And you don't really need it with the Tylenol. I talked to Dr. Offerdahl about these medications. No one really prescribes it in the world with if you want them to have it, just give it over, but the over the counter. It's basically tramadol or Ultram, 50 to 100 milligrams, 4 to 6 times a day. Don't exceed the 400. It's a dual acting. The narcotics work on the mu, delta, and kappa receptors. This one's going after mu. So does the hydrocodone. So does the morphine. But this one here, tramadol, works on inhibiting the neuronal uptake of serotonin and norepinephrine. So all you have to do is just be careful if someone's already on a blocker of that and they're already increasing. You don't want to give them too much. But if you just do 50 milligrams once or twice a day, you should be fine. That's out there. Just be aware of that little tidbit. This is what I use probably 8 out of the 10 times when I use my narcotic or my DEA license. This used to be not a controlled substance, and then it became a category 4 out there and on the street. They're known as trammies. So get used to, if you want to use this, these are very safe to use. A lot of people will say, be careful with the ibuprofens. If you look at the side effect profile, there's more issues with an NSAID than there would be with tramadol that's out there. So these are safe medications. Just have to be careful of the addiction, but it's a category 4. These really aren't anyone that could take it. They could be addictive, but this is not a highly addictive medication. Then the hydrocodone products that are out there. Again, you have to be careful because some are continuous release versus immediate release. If you're going to do it, you want to make sure you do a Vicodin that's an immediate release or a Lortab. You're going to see here that these are mixed with 5.5 of the hydrocodone or 5. I typically do, if I'm going to prescribe, and you're going to see where I do this, 5 milligrams / 300 of the acetaminophen. So the 5 is the hydrocodone, the 300 is the acetaminophen, kind of getting that central and peripheral acting. You're going to do 1 to 2 tablets or capsules. Sometimes they're in capsules, 4 to 6 hours for pain as needed. Now you're going to see here that a lot of the times we use morphine as the base to kind of see the strength of it. And you can see here it would take 20 milligrams of hydrocodone versus 30. So you can see it's a little bit more potent than the hydrocodone. So these are my 2 narcotics that I go for, and you're going to see the pain scale that I came up with and with working with Tracy to understand how all these medications work. And then I put this to use in my clinic over the years, and it seems to be standing the test of time. Now, codeine, Tylenol 3, it's the best ratio. It doesn't really work real well for eye pain. I've never had it really work real well for eye pain, but I wanted to point out that it's a weak analgesic when you compare it to morphine. Look, it takes 200 milligrams of codeine to get to that 30 milligrams. So that's why here hydrocodone as well. Remember that it was a Schedule 3, and then it got moved to a Schedule 2, and this is a Schedule 4. So if you want something for mild to moderate pain and a narcotic, tramadol is why I do it 80% of the time. The guy that ran the screwdriver in his eye, guess what he was getting? The guy that got the infection in his eye, guess what he was getting to go to Philly? He was getting Lortab to help him get that ride to Philly when he had that endophthalmitis. So we talked about these over-the-counters, Advil and Tylenol. And so what the key is that when you come to narcotics, there's no ceiling effect. That's why people become addicted. They need to get it and keep getting higher and higher and higher. There's no ceiling effect. With the peripheral acting, there is a ceiling effect. And what you need to know is that Tylenol, which is APAP, it has a 3,000. It used to be 4,000. It was like 2013 that they took it from 4,000 a day down to 3,000. To me, if you're treating chronic pain, someone that's going to take Tylenol every day for their back pain, for their hip pain, for their knee pain, be aware that they should only be taking 3,000. When I treat eye pain, and I know it's only going to be a day or two, I don't mind if they use this up to 4,000 times a day, right? This is cleared through the liver. Make sure their liver is healthy. Make sure they're not drinking that 4-finger Jack Daniels because that's now going to, you don't want to be taking Tylenol with it. And then ibuprofen, the maximum is 3,200 milligrams. Now ask yourself, what is over the counter? Over the counter is 200 milligrams. That means you're allowed 16 a day, right? 16 of those a day. When I say to patients down here, we talked about this, people were alternating. I tell them to take all 6 pills at the same time. Take the 4 ibuprofen and the 2 Tylenol, 6 at the same time. Take it with some food, big glass of water, and you'll get the effect of morphine. It's been proven. Go look it up. Go Google it. It gets to the pain threshold of morphine. It just doesn't stay there. Morphine stays up there, and eventually comes down. It gets up there, stays there, then comes back down. But that's why you want to take these pretty much all at the same time. Now I have it here. So you can see this is 800 milligrams. You could do that 4 times a day. 4 times gets you to that 32. You could take 2 of these. These are 500. You could do that 3 times. So if you take these 6 pills 3 times a day, I bet you could treat just about every ocular pain that's out there. And I heard a lot of people saying how they alternate that. Now, how do I choose 4-2 versus 2-2? You'll get good analgesic here with 2 and 2 If I have a inflammatory process, my guy ran a screwdriver, has a hyphema, probably going to be cycloplegia, probably going to need some steroids. I'm going to go 400 to get the anti-inflammatory effect. 200, you're not getting much anti-inflammatory. So if I'm just going pain, analgesic, 2 and 2. If I want to get some anti-inflammatory, 4 and 2. Just know your daily limits right here. So you could do this 3 times a day. You're safe. I wouldn't mind if they did it 4 times a day. You're safe on the ibuprofen. You're just hitting that upper limit of that 4,000, which used to be, but we're not treating chronic pain. So 4 and 2, 4 times a day, 2 and 2, 4 times a day, and you're safe. All right, so here's that pain scale. I pull this up from time to time, especially if I'm going to go with a narcotic. I like to make sure that, again, if I'm just treating pain, it's a scale of it. If I'm going a narcotic, I like to say that I use the pain scale. And if there are 1 to 3, you can use acetaminophen, ibuprofen, Aleve, maybe a 3. That's the problem with the pain scale. A 1, am I going to use Ultram? No. A 3, maybe, right? It depends on how discomfort they are. 50 milligrams. A 4 to a 6. A 4 is different than a 6. So you might do Ultram, maybe a 50 milligrams or 100 milligrams. You might go with a Tylenol with codeine. I really never found it to work real well. I'm not sure if you're going to go on a 6. We can't really prescribe Percocet, but we could do Vicodin. You could do like a 500, 300, and you could do that once or twice a day. So the pain scale is here. It's nice. When you get to the 7, we had a couple 6 and 7s in those traumas that I showed you. Tylenol with hydrocodone, Vicodin, 5/300. 4, up to 4 times a day. We're not going to really, any of us are going to have morphine that's out there. You start getting the 10s, morphine, hydromorphone, and fentanyl, and you get to the 10s that are out there. But that's why it's nice to have that trick of the Tylenol and Advil, but it's also nice to have Ultram and also nice to have your Vicodin. The ceiling effect, again, you don't have it with your narcotics. That's why when they get to tolerance, they have to give higher amounts. You don't get a ceiling, you have a ceiling effect with your peripheral. So Advil, if you give 800 milligrams, that's all you're going to get. If you give 1,000 milligrams, you're only going to get the power of 800. But in narcotics, the more you give, you'll get a little bit higher. But now you got the respiratory stresses and all the other adverse events. Constipation is one. And the key that you have to remember is even if you're going to use Ultram for 3 days, you want to let them know about constipation and to start Senna S. And I learned this from Tracy. She said, look, you don't want just a stool softener. You don't want the mush. What happens is the narcotic stops the intestine from pushing the material through. So she says you'll get the mush, but you need the push. So make sure that you're going to give the Senna S if anyone that takes a narcotic. I Googled it just recently to see if there was any change, went to Google Scholar, and they said, look, just get in front of it. Anytime you use a narcotic, that you should be prescribing a stool softener with a stimulant. And then the other side effects is sedation. So if I get someone that has a trauma and they say to me, hey, doc, this eye is killing me. I ran a screwdriver in it. I just need a good night's sleep. To me, that's ding, ding, ding. All right, I can't get that with Tylenol. I can't get that with Advil. I'm going to hit them with, an Ultram. I'm going to hit them with a Lortab because it's going to help them to sleep. The mu receptors will create a little euphoria, right? So people that take this, they can go, ooh, I feel pretty good. It doesn't mean they're becoming addicted. That's the euphoria that comes out of it. The kappa receptor, some people take it like, man, I got really nervous. I got like hallucinations. Those are your kappa receptors. And at times you get a histamine release and you get some itching, and sometimes it makes it nauseated by plugging into that chemotaxic zone that's out there. Joe, are there any questions on narcotics or anything to this point?
Well, a few things, and I think this one may actually go back toward the over the counters. How much should the patient's weight factor into your dosing recommendation?
Yeah, I don't do much pediatrics. I do a lot of adults and geriatrics. I get a little concerned when the 90-year-old woman comes in that weighs 90 pounds or man that comes in, not mainly because of their weight, mainly because how are their liver and kidneys functioning that's out there. I'd rather in those patients go with a narcotic, believe it or not, lower dose and better effect than some of those medications that are being cleared through the liver and kidneys, the ibuprofen, kidneys, and the liver for the Tylenol. But it doesn't take much because it's an acute problem. If it was a chronic patient, it might come into a little bit more play.
And can you go back? Would you go back one slide to the opioid effects? And what do you mean by re-explain, please? Mostly re-explain ceiling effect.
Oh, the ceiling effect is that, so in other words, that comes in with tolerance or the amount of coverage that you get from with the analgesic. So if I take Ultram, say 50 milligrams, or let's say I take 10 milligrams, and I become tolerant to that. Well, I can give 20, and then I can then have an analgesic effect, but then I become tolerant, then I can give 30. I can give 40. I can give 50. Tolerant, tolerant, tolerant. Keep giving a higher dose. It doesn't matter. If I get tolerant at 100, give 110. If I get tolerant at 110, there's no ceiling effect. If you become tolerant, you just give a bigger dose, you'll cover those kappa, mu, and delta receptors. Problem is, you're shutting down the breathing centers, and that's how these people die, and that's why they need Narcan, so on and so forth. Problem is, there's no ceiling effect. So when people want to get high and they become tolerant, that's why they shut down their respiratory system. You need Narcan to wake them up. And in peripheral acting like ibuprofen, there is a ceiling effect. 200, yeah, you can give 400, 400, you can give 600, 600, you can give 800. You're still getting more analgesic, 2, 4, 6, 8, up 10. You don't get any more bang for the buck. There's ceilings out there in the peripheral.
You're good.
Okay. All right. That's why narcotics are somewhat good at times. That's why the chronic, they change them around. All right, we have about 16 minutes here. I think we're good. I want to get through the steroid part. And we're going to use steroids mainly for hypersensitivity. Hypersensitivities come in acute. That's your type 1. That's a mosquito bite. You immediately swell. Cytotoxicity, antibody dependent. That's kind of your thyroid eye disease. Your body makes antibodies to attack the receptors. Immune complex. It's a broken immune system. These immune complexes float around. That's your lupus. And then here, your type 4 hypersensitivity is like a contact dermatitis to like nickel that's out there. So allergy and hypersensitivity, it's basically immune systems that have broken. So when you hear allergy and hypersensitivity, it's basically pretty much the same thing. So here's a patient that came in, is it conjunctivitis? Look at these eyes here. It's a glaucoma patient using Betamol, Alphagan 0.5, and Travatan Z. Which is the most likely agent? Well, it's going to be the brimonidine. The brimonidine over time in these higher dosages can create a contact dermatitis. 9 months, 12 months, 15 months. IOP is nice and low. Do I need a Medrol dose pack on this? I probably don't. I know what the affected agent is. I'm going to tell them to stop. Maybe use some topicals, and this will clear up. Now, is this a type 1 or type 4 hypersensitivity? It's not immediate. It's delayed. They're coming in contact with something. That's your type 4 hypersensitivity, and that's usually less itchy, but more redness and inflammation because it's different types of pathways. This patient was on it for 9 months. It's a contact dermatitis. Now, how about this patient that comes in? It's another brimonidine. It's 0.2 brimonidine, but she has her granddaughter's wedding this weekend. Doc, do you mean I have to go looking like this? No, I don't typically use Medrol dose packs, but since you have your granddaughter's wedding, I'm going to try and shut this down for you. So you can see within 5 days how well she cleared up here with her, stopped everything, stopped every glaucoma medication, checked her pressure, and said, okay, you're good to go. You look great for your granddaughter's wedding. We just saw this one the other day. You heard me mention Maddie. She's with me for a few weeks here. She's in her 3rd year and as optometry extern. This patient came in and he had this non-specific. I have a strike through here. I can usually figure out what causes it. He came back a week later. We tried finding it. Nothing. So all I'm going to do is label this as an allergic dermatitis. He came in. His eye was a little bit itchy. His eye was pretty much left alone, but you can see this kind of leathery appearance. We did a Medrol dose pack. He cleared up nicely. We saw him yesterday, Monday, for a follow-up. I was hoping he'd come back and say, oh, yeah, I was rubbing this on my eye. I didn't realize it. I was at work, but we never really found it. So I can't call it contact. We haven't found it yet, but it was an allergic dermatitis of some point. I told him he gets a free one. I gave him a note to give to his doctor for Cedrate, C-reactive protein, maybe an ANA. We'll see if anything happens. I told him it's like an iritis. He's allowed a free one, and we'll see what happens over time. So Medrol dose pack, it's methylprednisolone. It's great. I love it. We use it all the time. 4 milligrams is of methylprednisolone is equal to 5 milligrams of prednisone. So they get 6. I love it because they come in the packs. They get 6 on the first day, 5, 4, 3, 2, 1, a total of 21 pills that they get. And so this is the one you want to use. At times when I do these live, people ask, well, I see sometimes when I type it in, there's a milli pred pack. It's $400 versus $30 or covered by insurance. You could just use oral. If you're going to go with this, just go with an oral prednisone. But then talking to Tracy, there's different clinical pearls. And then on top of it, no one really prescribes it from a pharmacy standpoint. If you're going to use something, use methylprednisolone. 21 tablets, 6, 5, 4, 3, 2, 1. You'll get results like this or like this. It's a great medication that's out there. Now, when it comes to steroids, just be careful your patients with diabetes, even if they're pre-diabetic, just make sure they're monitoring their glucose. That's really the big thing when it comes to steroids. Watch that glucose. Pregnancy is a category C, prednisolone or methylprednisolone. Make sure you ask if the patient is pregnant. Children, stay away. So let's say 18 or younger, it can suppress the growth. There's increased side effects, especially in that immune response and that hormonal imbalance and bone issues. So avoid in children. GI upset, so make sure you take with food. And really, we always hear about the fat redistribution, the osteoporosis, cataracts. That's more your long-term side effects that's out there. So, for our gentleman that we had, we just wanted to make sure he wasn't, you could see he's definitely older than 18. He was in a glaucoma, no risk of being pregnant. So it was a really easy medication to prescribe. With that being said, kind of in that allergy range and it's seasonal allergy time. So remember that in the allergic reaction, that antigen, let's say the red dots here are the pollen, gets into the conjunctiva. That pollen plugs into this antibody that has become sensitized. So this is a mast cell. The antibody now touches the mast cell. It allows histamine and heparin to be released. In the long term, the phospholipids, the arachidonic cycle, leukotrienes, prostaglandins, and then that's what it looks like in the early phase. Histamines, eosinophilic chemotactic factor A, heparin. Right here is what the eye looks like along with the conjunctiva. In the late phase, those leukotrienes start beating up on the blood vessels. Basophils and eosinophils, which are white blood cells, leak out. Those white blood cells have all kinds of enzymes. One of them is hypochlorous acid that we use for treating blepharitis. And then you end up with that cell-mediated tissue edema type of reaction. This is what happens in a late phase. We know this as a flectenule. What color is this? Flectenules could be on the conjunctiva, could be on the cornea. You see the redness. This is your cell-mediated cytotoxicity, white blood cells. This is a flectenule. This tells me this has been going on for a while, or it's one heck of an immune response. I've been working in my yard for 2 weeks. My eyes are red and irritated. Yes, they are. She has both early phase and she's moving into the late phase with this type of reaction. So we can use things like loteprednol. You could use your prednisolone, but probably once we stop, she's probably going to need maybe like a Zyrtec or an Allegra, and we're going to talk about that. So I've been working in my yard for 2 weeks. There's the histamine phase. We have the white blood cells kind of showing up. We have the eosinophil and basophil phase. Here's a 25-year-old man. My eyes are red and itchy all year round. I do cold compresses, artificial tears, Pataday. I work in the public. I'm a financial consultant. No one wants to give me their money because they think I'm smoking it all the time once you see my eyes. I also have asthma. I use inhalers. It tells me that they're kind of more of an atopic person. Look at this here. He has the inflammatory. This is the cell mediated that's creating tissue damage and redness to his eyes. Look at the ulcerations that are occurring here. So we put him on I did a Medrol dose pack to help clear him up. I also did some topical steroids. I would give him some money. I'm not sure if I'd give him money to invest. I would definitely give this guy, right? So just think if you're going in and wanting to give, and this is just all hypersensitivity that's out there. So atopic keratoconjunctivitis, basically atopy is a condition where the immune system produces higher than normal antibodies, usually that IgE, high levels of IgE creating all these issues. So when it comes to oral allergy medications, Claritin, Allegra, Zyrtec. They used to be prescription. Now they're over the counter. There are differences. I remember Zac. It's easier to me to remember Zac. Z-A-C. Zac is the strongest. In pharmacology, you always want to start weakest and go high. So Claritin is the weakest. Remember the commercial, Claritin Clear. And with that said, at the onset is 1 to 3 hours, low sedation rate out there. But Allegra is a little bit stronger. Zyrtec is stronger, and you have a higher incidence of the sedation. I can tell you from ocular times, because it's weaker, they are different. I hear people all the time say, well, do this, do that. You could do a step-through therapy. Claritin in the eyes will typically fail. It will work, but typically fail. I'm usually in the Allegra or going to Zyrtec, but more importantly, typically Zysol. So there is a difference. Claritin is the weakest, Allegra and Zyrtec. Some clinical considerations. They're all once-a-day dosing, which allergy sufferers want. If you want the least sedation, that's Claritin because of Claritin Clear. Allegra is a little bit more rapid with minimal sleeping effects, CNS. Zyrtec, you're more likely to get some drowsiness, and there's no significant QT prolongation as you can get with some of the other histamine blockers that are out there. So now where does Zysol fit in? Zysol fits in as an isomer of Zyrtec. So basically it's like a prodrug. It has less sedation. So if you're going to go to Zyrtec, just jump them over to Zysol. So the way I kind of look at it is Zac, Zyrtec, Allegra, Claritin. If I'm hitting the Z, I'm going with the X of Zysol. And the takeaways are Zysol is often preferred for patients needing stronger symptom control. So this person is a Zysol person. This person is a Zysol person. Some of these other ones that are out there that we see, that first one that I saw might be an Allegra, that one that I showed you where we flipped the eyelid, or that could maybe be a Claritin. So they have different strengths that are out there. So be aware of that now that allergy season is coming up. So I just put this together, Zac and Zysol. You can see here Claritin, slow onset, minimal drowsiness, non-sedating, best on an empty stomach. This is good, but it has some sedation. Pretty much probably the best balance out there if you need to go potent would be Zysel and Allegra is where I am all day long. Zysel and Allegra, at times Claritin when you're treating. So this is a patient here, happened 2 years ago, my seasonal allergies. This could be an Allegra to start off with. Probably Claritin wouldn't touch it. Start them off with Allegra. If they needed something stronger, bump them up to Zysel. Zysel's going to give them a little bit more sedation, or they could be a little bit more tired. So this patient here, treat them with the topicals, all the other stuff, wash your hair, do this, do that. We're talking orals tonight. This would be start with Allegra because it's not going to make you tired. Jump to Zysel. I probably avoid Zyrtec because of the sedation that's out there. And that's seasonal allergic conjunctivitis. All right. Let me do this, and I won't get to the antibiotics. Let me just run this quick polling question. I have a question here, and I'll make sure we're wrapped up right at that 9:20 or 9:21. All right, so I have a question. All right, this one here is, let's see, I think I have them open. Yep. Patient with angle closure glaucoma, IOP is 62, has an allergy to Bactrim, mild hives. He actually has a picture of it. He took some Bactrim and he got these hives on his arm. Would you give him oral Diamox? Yes or no? Remember, Bactrim's a sulfa, and so is Diamox. Give him sulfa medication, Diamox. And then have you ever prescribed Trusopt, Azopt, Cosopt successfully on a patient with a sulfur allergy? Yes or no?
Very quick question came in. Do you ever use topical steroid on eyelids for flaky, dry, allergic dermatitis?
Sure. If I do, it's usually hydrocortisone cream over the counter if I'm going to do it. At that point, it says not to use in and around the eye. I tell them, look, don't squirt it in the eye, but if it's going to be on the eyelid, I would most of them have hydrocortisone 1% cream at home. I tell them, don't be afraid to use it 3 or 4 times a day and see what happens. All right. So let's see here. I'll display the first one. It's a nice split. We have 56 saying no. I'm going to close that one. And then over here, have you used it? 20%, no, 25% said yes, not sure, glad it worked. The other 20% said yes. We have a majority that said no. All right, let me just talk about this for about 2 minutes here, and then we'll get this wrapped up. All right, so when it comes to a sulfa antibiotic allergy, here's the key. See the word antibiotic? When they're allergic to the antibiotic, they're not allergic to the S, the sulfa. They're allergic to the aryl amine group. That's this 6-sided thing with this H2N. This is the antigen. This is the hapten. It has to be that they're allergic. This person was allergic to Bactrim, the antibiotic. If they're allergic to the antibiotic, they're not allergic to the S. They're allergic to the aryl amine group. So when you come down and you do your sulfur allergy, if they're allergic to the antibiotic, here's your aryl amine group right here. And all your sulfa antibiotics like Bactrim fall in here. You wouldn't want to give them an antibiotic. However, if they are you could possibly, or low risk of cross reaction when it comes to Diamox and Neptazane, Trusopt, Azopt, Cosopt. That's why you can do it. If someone has a sulfur antibiotic allergy, it's the antibiotic, they're allergic to the aryl amine group. This does not have an aryl amine group. It has an H2N, but it doesn't have the hexagon structure to it. So if someone was going to come in with a pressure of 62 and they had a sulfa antibiotic and I'm at risk of angle closure and blindness, and it was hives, it wasn't an anaphylactic, I would feel pretty safe giving it. If someone had a sulfa antibiotic allergy and they had glaucoma, we've all given them Trusopt and Azopt and Cosopt, and it hasn't had a reaction because the antibiotic is the aerial amine group. If you jump over here, that's why atropine. Don't worry about someone has a sulfa and it's a atropine sulfate and gentamicin sulfate or sulfite and neomycin. These are all sulfate, sulfite, and sulfur based. There is no cross reactivity. They all have the S, but this is the aerial amine group. So this is important in Joe's arena. He works with pseudotumor cerebri all the time. If they have pseudotumor cerebri, they might need Diamox, and they might be told not to take it because of their Bactrim allergy. I would give a test dose and then treat the patient. All right, so that should solve that. So you can do Diamox, which would be 500 milligrams or 250. They always say stay away from the sustained release. If they have it in their office, and that's all. If they have a closure in your office and that's all you have, give it to them. We try to keep the immediate release in the office. And Joe, I'm going to have to leave them to come back and maybe do some oral antibiotics at some time.
That sounds good. We're all good here, Greg.
Here's a nice little QR code if you want to watch the have this on our YouTube channel. It's a 9-minute review of basically how to prescribe these in a safe way. These are good for pregnancy and what to watch out with. What changed was Cipro got moved down to the 5th spot. And we'll come back and do an antibiotic lecture in the future. I think most of us feel comfortable. I wanted to cover the uncommon tonight that's out there. So there's a quick review. And right now, you should see that little red dot on your survey. You can do that right now. There's that little red dot right there. Start your survey. And Joe, are there any other questions that have rolled in?
No, we're really good.
Okay. So with that, we're caught up. Questions have been answered. It was a very interactive audience tonight. Polling questions went well. I want to thank everyone. Thank everyone for taking oral pharmaceuticals for eye care, the common, the uncommon, and beyond. This was a synchronous course. Joe, thank you for being here and helping me out with the polling questions and being a great moderator and giving insights. It was an honor and a pleasure to be here with all the colleagues tonight.